Alright guys, welcome to chapter 3 of the guidebook, and in today's guidebook chapter we'll be discussing the arrhythmias, how do we diagnose them, the different ECG findings that we have, then we'll be going over what is WPW or Wolff-Parkinson-White syndrome, then the role of adenosine, then how do we go over the treatment of each of these arrhythmias. Now, to start off that, again, this is the third chapter for the cardiology block, and after this we just have one more chapter left, chapter 4, in which we'll be going over hypertension, and after that we'll be done with the cardiology block, and then you can start revision along with me. And just to let you know, these are not, as I said in the earlier videos, exhaustive explanations of all the topics in John Murtagh or all of the important topics. However, these videos are meant to be a sort of revision for myself, because I have my exam in about 2 weeks and I need to get all of these done, and this is the way I find that I stay motivated to study and be on time. So later on after my exam I'll be making in-depth videos about all of the different topics that are important for AMC, and going in complete detail about them. Alright, so to start off we'll be going towards the first topic of today, which is the epidemiology and key facts. And the important fact that I want to talk about is that why do I have epidemiology stated for every single disease that we are discussing. The reason for that is because epidemiology, it's not the most important to memorize all of these percentages. For example, that 20% for ventricular ectopic beats, or then it's atrial fibrillation and then PSVT. It comes down to the fact that sometimes AMC is going to give you stems in which the signs and symptoms match maybe 3 to 4 diseases. All right, so all of the facts, signs and symptoms that are given in the stem are going to match let's say 2 or 3 diseases. Now, based on the patient profile and the prevalence, you are expected to choose the disease that's the most common amongst them. And that's the reason that I have epidemiology listed for all of the chapters. All right, now, so let's start with epidemiology and key facts. So to start off, we have ventricular ectopic beats. So this is the most common arrhythmia. Sometimes it's physiological, sometimes it's non-pathological, especially in young children, especially in athletes. It's more commonly seen in them, but it's not problematic most of the times. So 20% of patients with normal hearts, it occurs in 20% of people with normal hearts. And atrial fibrillation is the most common sustained arrhythmia, right? And later on we'll be going over the fact of that, what does it mean that something is sustained or non-sustained. So, and the way we deal with sustained whereas unsustained, stable and unstable patients is completely different. All right, so in sustained, so 1 to 2% population, so 9% in those over 65. So you see there's an age, so that's a patient profile that we need to keep in mind. Then PSVT, so paroxysmal supraventricular tachycardia, is 6 per 1,000 of population, and WPW with AF development is up to 30% of W patients will develop AF or flutter. So in all of this text, AF is fibrillation and VF is also fibrillation. All right, flutter is stated as flutter. Now, going over the fact that flutter and fibrillation, for a long time for myself, I used to confuse them a lot, not just the ECGs but what it meant, and comes down to the fact that what is the main difference between fibrillation and fluttering of the heart, of the cardiac muscle. So the way I like to remember is that while doing CPR, the shock paddles that we have, we call them defibrillators. All right, but we don't call them deflutters. Right, so defibrillator, so fibrillation is the the way we know that the heart muscle contracts is that it goes in proper sequences, right? So first we have the atria, so first we have the atria contracting, and then the fibers go down, we have the ventricles contracting, and then they go up and repolarization occurs. In fibrillation, all of them sort of just shiver on their point. All right, and there is no proper complete contraction, and that is comparatively to ventricular flutter, that's more dangerous. So the way I like to remember fluttering is that it's like the fluttering of the wings of the butterflies. Because they flutter, there is some contraction, but it's not where it's supposed to be. And sometimes we have, ectopic beats, or because of other reasons. We'll be going over the reasons as well for the arrhythmias. But from my understanding, fibrillation is a lot worse than flutter. All right. So that's one way of differentiating between them, and this can easily be seen in the ECGs, and we'll be going over the ECGs later on in this chapter. All right. Now moving on to the systemic approach to tachyarrhythmias. So right now we'll be discussing tachyarrhythmias. So the first question, which is the most important question, is the patient stable or unstable? All right, and that means that we see what are the hemodynamics of this patient. So if it's unstable, that means that the systolic blood pressure is less than 90 mmHg, there's chest pain, altered consciousness, acute pulmonary edema, and regardless of arrhythmia type. So could be EF, could be VF, could be VT. We see if the patient is stable or not. Then if the patient is unstable, remember, for all, if any patient is unstable, we do immediate synchronized DC cardioversion, and we do not delay, and we don't wait for drug therapy. Then after seeing if the patient is stable or unstable, we see if the QRS is narrow or wide. So if the QRS is narrow, that means the normal QRS is 120 ms. And if it's less than 120 ms, that means that the tachyarrhythmia is supraventricular in origin. All right. Such as the Atrial or the AV node. And if the QRS is wide, that means that ventricular origin or SVT with aberrant conduction. So aberrant conduction is when the conductive pathway takes a different path than the actual original, the physiologic path the conduction should take. Right. So if it's wide QRS tachycardia, treat as VT until proven otherwise. So every single time we have a suspicion and it's an emergency, we always treat, keeping the worst prognostic disease in mind. So VT until proven otherwise. So the next thing to consider, if it's narrow plus stable, and is the so if at this point the patient is stable and their QRS is narrow. All right, and this point we consider if the rhythm is regular or irregular. So regular narrow is sinus tachycardia, PSVT, or atrial flutter with 2 to 1 block. Irregularly irregular could directly mean atrial fibrillation, which is dangerous. And especially we have to start considering coagulations, and later on we'll be going over the CHA₂DS₂-VASc 2 score, and based on that we need to keep that treatment in mind. And the action is that if it's AF, then that means it's irregularly irregular. PSVT is abrupt onset and offset regular. Then what is the rate? So a rate of about 150 BPM suggests PSVT, atrial flutter, fibrillation, or VT. A rate less than 150 is going to show a sinus tachycardia due to drugs, fever, and exercise. So this is going to help us classify before we get a confirmation using the ECG. All right, and now this is just a table for us to go over the different rates, different QRSs, different rhythms, and the key ECG features that we'll be seeing. Now, to start off, we have sinus tachycardia, which is, I think, the easiest one. And I don't know, so I don't know if you guys have an easier way of calculating sinus tachycardia, but this is the one that I prefer. So each big box, so the way I like to do is that you count the small boxes, or you just count one big box. The small boxes is more accurate for smaller readings, or sometimes, in most cases, the ECG isn't going to be perfect in the ER, and there's going to be small boxes here and there that overlap, or the ECG isn't going to like in this diagram that it goes over 5 or 10 boxes. So small boxes helps out a lot, but the fastest way to do is that one large box means 300, 2 boxes means 150, and 3 boxes means 100. And the way it works is that we divide 300 by the number of large boxes we have. And this is the fastest way. We used to use this in the ER sometimes, and because in the ER we have less time to diagnose and treat the patient. So this is one way. All right, and I think this is the easiest way for me, at least. So this is what a strip of sinus tachycardia looks like. You can see that let's use what we just learned and try to calculate the rough approximate BPM. Let's zoom in here. So we have 1, 2, 3, 4, 5, 6, 7, 8. Let's call it 8. 1, 2, 3, 4, 5, 6, 7, 8, 9. So basically 8. So it would be 1500 divided by 8. All right. So I would say close to 150 BPM. So yeah, so that's the one that's given here, 150 BPM. And you can see that the QRS complexes are very narrow. All right. But we always see in this particular ECG, we see a P wave before the QRS is going to before we see the QRS complex. All right, here again P wave, then this is T, this is P, then we have QRS. All right, excellent. Then P waves are hidden within each preceding T wave. In this, it's still clear. In the next ECG, I'll be showing you this one. It's still there, but you see that it's not, how we are used to, that's the, so you see this gap between them, it's gone completely. And this is what we call a camel hump appearance. So very fast heart rate, again, if we calculate, so this is 5, 6, 7, 8, again, this is 150 BPM. All right. So because of that, we can see camel hump appearance in this. And AMC might trick you into considering that this is something that's pathological, but it's not. It's just sinus tachycardia. You can see it's regularly irregular. So if you can go over the last video, we went over the pathway follow for deducing an ECG. Now coming up to PSVT or SVT, the rate is going to be significantly higher than normal tachycardia. QRS again normal, and the rhythm is regular. All right, so abrupt onset and offset, P waves are absent in this, or retrograde. That means they're hidden between under the T waves itself. All right, and there is a sudden onset and otherwise healthy young people. Now, if you go over here, I'll see if I have, yeah. So SVT classification, we cannot see a P wave in this. All right, narrow QRS again, and yeah, so. We see that it's 1, 2, 3, 4, 5. Basically, it's one box, which is close to 300, which is very dangerous. Yeah, so in this example, so this is atrial flutter with rate block, but SVT, we can't see the P wave, and it's a very high BPM. Now coming up to atrial flutter, the way I like to think is that the flutter has double T, so it's going to ta-ta-ta, all right? So that's just one weird way of remembering, and you guys should also make your own weird way of remembering, because that's how you'll remember it better. So the QRS again is going to be narrow. So all tachyarrhythmias, you have narrow QRSs. Rhythm is going to be regular, and there's sawtooth. So flutter has 2 T's, sawtooth has 2 T's. All right, and waves are 300 per minute and 2:1 AV block most of the time. This is the most common, giving the rate of about 150. So there is a QRS rate, which is the ventricular rate, and then there is the atrial rate, all right, because it's an atrial flutter. And it's the same way that we calculate the BPM. So now coming up to this atrial flutter, you can see that there's sawtooth appearance. And one way also that I like to remember is that flutter has a U, and these waves look like U's, right? I mean, to me at least. So that's what they look like, because a lot of the other ECGs also look like sawtooth to me personally. So that was one way I used to get confused between VTech, ventricular fibrillation, ventricular flutter, and atrial flutter. Because if you know those ECGs, you can see that those also look like sharp sawtooth, but flutter, I mean, easiest way, these look like U's, right? So coming up to the ECG reading, is that there is an inverted flutter in waves 2, 3 plus AVF with atrial rate more than 300 BPM. There's a positive flutter in V1 resembling the P waves, which are not true P waves. And the degree of AV block remains 2:1, 4:1. So 1, 2, 1, 1, 2, 3, 1, 1, 2, 1. So it's varied. Again, we see 4 here. 1, 2, 3, 4, and then 1. All right. So it's not regular, it's irregular. Yeah, so it can be regular or irregular, but usually it's regular. Now coming up to atrial fibrillation, rate per beat per minute at 60 to 180. Again, QRS is going to be narrow, and rhythm is irregular. All right. Now in the ECG features, we have no P waves. undulating or fibrillatory baseline, irregular RR intervals, so irregular tapping all over the place, tapping. Again, this was an atrial flutter, and there we go, fibrillation, completely irregular, and this is without visible P waves. Now this is a hallmark for atrial fibrillation, that there are no visible P waves. All right. Now coming up to VT, ventricular tachycardia, which is monomorphic. QRS surprisingly is wide. All right. Then rhythm is usually regular, and there is AV dissociation. So P waves are independent, and a lot of the beats get fused together, especially in the concordant chest leads, and that's why we can see the wide QRS complexes as well. So there we go. Positive concordance in VT. So lead V1 to V6 shows entirely positive R complexes with no RS complex seen. Right. Good. We can see that the QRS complexes are, really wide compared to what we were seeing before. And this is because of the rapid beat. The repolarization is taking a lot of time, and that's why when it goes towards depolarization, it takes a longer time for us, for the heart to depolarize, giving us a wide QRS. All right. Now coming up to ventricular fibrillation. So it's completely chaotic, and this is an emergency. And no QRS, chaotic irregular, chaotic undulating baseline, no identifiable QRS, and it's basically cardiac arrest. Now, if you've done BLS, ACLS, so it's one of the shockable rhythms. This is ventricular flutter. All right, this is what it looks like. It's monomorphic, but yeah, important point is that ECG is going to look completely the same when it's turned upside down, because there's no shape to the ECG. Then Wolff-Parkinson-White syndrome, usually seen in patients that have atrial fibrillation, or also in athletes who have ventricular tachycardia and they have been given adenosine, and then suddenly they deteriorate, and on the ECG we see that it's Wolff-Parkinson-White syndrome. And this was a question a few days ago that I saw in one of the ECG questions. So it has short PR interval plus delta waves. Now delta waves are the most important for Wolff-Parkinson-White syndrome because it's definitive for that. So ECG shows short PR and slurred upstroke, right? Now this is what it means, that there are delta waves. These are delta waves, all right? So the PR interval is a lot shorter, and suddenly there's now a delta wave. So there are 4 different types of physiologies that this delta wave can have, and this could be a notched delta wave. It could be an we can see a positive depolarization on the delta wave. We can see a hump, and then suddenly it's like that, and then we can see sometimes that it's completely fused into the R wave. Now the example I have over here is the notched type. All right, you can see that. Sorry, not the notch type, the one that's completely under the R wave, right? Here you can see that it's slowly going towards that. All right, so very short PR interval and broad QRS complexes with a slurred upstroke to the QRS complex. Dominant R wave in V1 suggests left-sided AP and is sometimes referred to as type A WPW. So, I haven't come across any question that asks us, what different types of WPW there are, but it's a good thing to remember them. So, tall R waves and inverted T waves in V1 to V3, mimicking right ventricular hypertrophy. Then these changes are due to WPW and do not indicate underlying right ventricular hypertrophy. We can see those here, V1 and V3. You can see how large these depolarizations are. It will be difficult to deduce if the patient has actual hypertension or actual cardiac hypertrophy, or is it just WPW. So negative delta waves in AVL simulating the Q waves of lateral infarction. This is referred to as pseudo-infarction pattern. All right, so we have pseudo-infarction in the ECGs as well for WPW, but again it's clinically based. If the patient profile matches WPW and in the ECG we can see delta waves, then it's most likely going to be WPW. All right, now coming up to the first tachyarrhythmia which is atrial fibrillation, and arguably the most important, because a lot of the questions can be formed from this one pathology. So to start off, it's a common problem. So this is what, so blue boxes are what I've taken from John Murtagh. Yellow boxes are my, the pseudonyms or the short forms I use to memorize important information. And then we have, let me see if I can find any, these red boxes. These red boxes are essential because there are a few traps that the AMC can place to confuse students. So it's essential that you go over all of them. All right. So now coming up to atrial fibrillation, is the most common problem, especially over 65 age group, presents with an irregular ventricular rate. Apart from acute AF, which is a new onset, less than 48 hours, it tends to fall into one of the 3 Ps. Paroxysmal AF, which has an abrupt onset, spontaneous return to normal rhythm, usually lasts less than 48 hours. Persistent AF, abrupt onset, again lasts more than 7 days. Then permanent, which is chronic AF, and it cannot be converted to normal rhythm. It's just what the patient has. And sometimes I've seen in questions, I've seen in practice as well, that the patient comes and surprisingly they have an AF and it never bothers them. There was one case in the ED where a patient came and they said that they could feel their atrial fibrillation, they could feel those palpitations and their heart going off beat, which was surprising to us, but we did check, and yeah, so they had atrial fibrillation that they could feel. So all types appear to have a similar risk of thromboembolism, and we look for underlying causes always. If it's a myocardial ischemia in 15% of cases, because you can think about that if there is ischemia of the cardiac tissue, then that means that the conduction is going to be affected. So every single time there's damage to the cardiac tissue, whether it's prolonged ischemia, MIs, trauma, placement of valves, drugs that are going to affect the conduction. So we'll be going over this reason, but every time you need to think that logically that the conduction system is like a wiring and it's going to be affected. And then again, mitral valve diseases, then thyrotoxicosis and hypertension is 60 to 80% association. And why is hypertension so important? Because of hypertension, we're going to increase the cardiac tissue, the cardiac muscle that's supposed to contract. That means we'll have more fibers, more aberrant pathways, more chances of getting an AF. All right. Then pericarditis, DM2, cardiomyopathy, including chronic alcohol dependence, alcohol binging, and no causes found in about 12% or isolated or lone AF. Now, causes of AF, I've seen a lot of the questions based on these different causes. The causes are given, we have to deduce, and then sometimes we have to also add what could be the reason and how do we treat it. So to start off, we have ischemia, I. So the short form is I patch MD for AF. All right. Then P for pericarditis and pulmonary embolism, A for alcohol binge, drinking, and holiday heart. I've seen questions on this as well. This is an important term, holiday heart, that the person goes on a holiday, has a lot of drinking, and comes back with an AF, and you have to fix the patient. So thyrotoxicosis, and to be honest, all patients deserve, so this is a principle to always keep in mind, no matter the belief, no matter the background of the patient, no matter the condition, we have to always make sure the patient is comfortable and receives the best care that we can offer, right? That's our responsibility as doctors. This is the least we can do. Then T is thyrotoxicosis, which is masked thyrotoxicosis in elderly especially. Then C for cardiomyopathy, dilated, hypertrophic, alcohol-related. Then H for hypertension, 60 to 80% associations, according to John Murtagh, and then heart failure. Then M is mitral disease, so especially mitral stenosis. So when do you get mitral stenosis, or which is, what are the different reasons? One could be, calcification. So especially in old age, or amyloidosis, or there's calcium deposits on the heart, or there are some other deposits, there are vegetations in the heart that could lead to mitral stenosis. All right, so, and mitral valve disease, warfarin is required, but not DOAC. I kept it here because it's a really important point. And then later on, we'll be going over the different pathways of treatment, but these are a few important points. Then we have, the most important one that we see all always, diabetes mellitus. And so this is the most important. Then we also have drugs, so stimulants, cocaine. So now moving on to the CVA, which is CHA₂DS₂-VASc score that we need to assess. So what is the reason that we have a CHA₂DS₂-VASc score? It tells us that what type of, if we need to give a patient with AF anticoagulation, and if so, then what type. All right. Now in CHA₂DS₂-VASc, I've seen a lot of questions with this. They literally won't give you that you need to calculate CHA₂DS₂-VASc, but you have to remember, if they ask you for a treatment for AF and what pathway to follow, you have to get the CHA₂DS₂-VASc right. All right, so CHA₂DS₂-VASc, C, congestive heart failure, any type of heart failure in the past, 1. C for congestion, 1 point. H, hypertension, treated or untreated, 1 point. H for hypertension, 1 point. Then age, if it's more than 75, we get 2 points. So you see it's how CHA₂DS₂-VASc. So age has 2 points. So double points for extreme age. All right. So D is diabetes mellitus. I haven't come across this extreme age factor. I was just saying, maybe 70, 80, 82. That's it. So diabetes mellitus is 1 point. S2, so any history of stroke, TIA, thromboembolism is 2 points. So double points for prior stroke. V, vascular diseases. If they had any prior MI, PAD, aortic plaques, then 1 score. V for vessels, and 1 point. Age between 65 and 74 is 1 point. So lower A for lower age titer is 1 point. Then the gender of the patient. So if it's female, it's 1 point. So for female, adds 1 point always. Then maximum possible score is 9 for CHA₂DS₂-VASc. So we're giving a score out of 9 for assessing CHA₂DS₂-VASc. So the score for male and female is different because this factor, the gender of the patient's factor. So in male, if it's 0, and for female, if it's 0 or 1, then no anticoagulation is required. All right. And if for male it's 1 and female it's 2, then we consider anticoagulation. So cardiology review recommended. And if it's more than 2 for male and more than 3 for women, we commence anticoagulation unless contraindicated. So if the patient has a high bleeding risk. Now, what could be a high bleeding risk? It could be a recent trauma. It could be, an ongoing treatment for a stroke. It could be internal bleeding. It could be peptic ulcer disease, an ulcer that already, a hemorrhaging ulcer. All right, so there are a lot of different high risk, but you have to consider those while we're giving treatment for anticoagulation. All right. Now, choice of anticoagulation, this is a very important table, because once we can find if the AF is valvular or non-valvular, all right? So in non-valvular AF, which is the most number of cases we'll see, DOAC is preferred. So apixaban, levodoxaban, or dabigatran is the preferred drug. If it's valvular AF with moderate mitral stenosis or mechanical heart valve, so warfarin only is the treatment of choice, and not DOACs. All right. Now, if the creatinine clearance rate is less than 30 ml per minute, DOAC are contraindicated, so we use warfarin only. So we have this another factor in play. And we never use aspirin or clopidogrel for AF stroke prevention. All right. And the target INR for warfarin is 2 to 3. And then later on, we'll be going over the other chapters. We'll be going over, patients who had AF that come for some treatment. Some of them have acute intervention. Some of them have voluntary, interventions. And then we have to stop that warfarin and get this INR down. And there is a different pathway for that as well. All right. Now, coming on to the difference between rate versus rhythm control. What does it mean? And what is the benefit of doing rate control versus rhythm control? So now, I think we went over this in our previous chapter as well, what would be the difference between rate and rhythm control. But anyways, we'll go over it again. So rate control, it accepts AF, control ventricular response rate. Rhythm would be to convert to and maintain sinus rhythm. All right. Now, what do we choose these for? So rate control would be asymptomatic, good LV function, permanent AF, and elderly. All right. And rhythm control would be for symptomatic. So this was asymptomatic, this is symptomatic despite rate control, poor LV function, young patients, first presentation of paroxysmal AF. So it's the complete opposite. All right. First line of drugs for rate control are beta blockers, so or non-DHPCCBs. All right. Diltiazem, such as. And rhythm control, we use rhythmic drugs such as amiodarone, This is the most effective for conversion and maintenance. And flecainide only if no structural heart disease. All right. And the warning in Murtagh was given for CEI and reduced ejection fraction. All right. Then in AF plus heart failure, for rate control we give digoxin, and for rhythm control again we give amiodarone is preferred in heart failure. Flecainide is contraindicated and reduce LV function. Remember, flecainide was being given when there were no structural heart diseases. Right. Then we have precardioversion. So rate control would be anticoagulate for more than 3 weeks before elective cardioversion, or rule out AA thrombus with TOE. All right. Then rhythm control is the same, but we must anticoagulate. All right. And we anticoagulate with warfarin 4 weeks beforehand and maintain 4 weeks afterwards. And this was cardioversion. All right. Now the rate target is 50 to 100 beats per minute at rest, ideally less than 90. And then for rhythm, of course, the main aim or the final goal is sinus rhythm. So Murtagh critical trap is to never use digoxin or verapamil in Wolff-Parkinson-White syndrome plus AF. All right, and these drugs block the AV node but accelerate conduction through the accessory pathway. So ventricular rate can exceed 300 beats per minute, which gives us VF and then sudden cardiac death. All right, so WPW plus AF, use flecainide or procainamide if the patient is stable, or DC cardioversion again if the patient is unstable. Unstable patient, we always give DC cardioversion. All right, so in this, because there is no structural abnormality, we're using flecainide, and if there was, we can use procainamide. All right. Now moving on to SVT, it's one of the, I would say, the second most important topic, because in this we don't get the diagnosis or the the clinical picture. We don't get the the future treatments. However, we do get this vagal maneuver. All right. I've seen a lot of questions about vagal maneuver. Then we move on to adenosine and then verapamil. And a lot of the questions are just based on these first two steps. All right, so SVT rate is, as I said, 160 to 220 per minute. PSVT is commonly presents with sudden onset and otherwise healthy young people, and passing copious urine after an attack is characteristic of PSVT. So if a patient comes and they've soiled their pants, you have to think differential PSVT. And approximately 60 are due to AV node re-entry and 35 due to accessory pathway tachycardia, so WPW. So management, first line, vagal stimulation, blowing hard into 20 ml syringe or blowing hard into a bag, and then or blowing hard into the fist of the patient, asking the patient to blow into their closed fist as well also works. Then number 2, second line is adenosine. IV, you have to remember this, 6 mg first over 5 to 10 seconds, then 12 mg in 2 minutes if unsuccessful, and then 18 mg. So we are going from 6 to 12 to 18. Then second line is verapamil, and for this dosages are important. All right, because you will get questions with the timings, especially for adenosine, and you have to select the right answer. So verapamil IV, remember verapamil is IV. All right, and so was adenosine, because there are questions that give you oral, or let's say they give you IO. All right, so IV is the right choice. So 5 to 10 mg over the 2 minutes. Then metoprolol IV, again 2.5 to 5 mg. We avoid verapamil if taking beta blockers. And so if the patient has beta blockers, we don't give verapamil. And you can think because that could lead to severe hypotension. All right. And then third step is DC cardioversion if failure of medical treatment. All right. So we start with, the easiest action, which is vagal maneuver, drug-free. All right. And and then we move on to adenosine. Again, the dosages are important. We use anticubital vein because it's closest to the heart, and flush immediately after we give them adenosine, because sometimes some of the drug can remain within the catheter that has been placed in. All right, sorry, the cannula, we used to call it catheter, but the venous cannula that has been placed. All right, then we wait 2 minutes and then we give 12 mg, then wait 2 minutes, we give 18 mg. So 2 2 2 and 6 12 18. All right, so First one is going to be over 5 to 10 seconds, the 6 mg rapid IV bolus. Then we move on to 12 and then to 18, and then between them is supposed to be 2 minutes. And keep in mind, this is because the patient is not improving. All right, so the patient can have brief flushing, chest tightness, feeling of doom that lasts a few seconds. All right, then the question for the adenosine is bronchospasm and asthma, and avoid and pre-excited atrial fibrillation and WPW. Then verapamil IV is second line, 5 to 10 mg IV over 2 minutes, and if effective but still tachycardia, repeat after 30 minutes. All right, so in this we are doing 2 minutes, in this we're doing 5 to 10 mg over 2 minutes, but then after 30 minutes, if it's still tachycardic, we give them 5 to 10 mg again. All right, so if the QRS and blood pressure is more than, if the QRS is narrow and blood pressure is more than 80 mmHg, so this is when we repeat it again. All right, so we avoid if taking beta blockers. Combined can cause severe bradycardia and complete heart block. So bradycardia, heart block can occur because of beta blockers plus CCBs. Then metoprolol, we have a beta blocker here, 2.5 to 5 mg IV over 2 minutes. We had 5 to 10 over here, then we have half of that, so 2.5 to 5 mg over 10 minutes, and then repeat after 10 minutes if ineffective but well tolerated. So caution again, bronchospasm and asthma for beta blockers. Then in unstable patients, I've never seen that they ask you for joules, but 200 joules biphasic, you'll learn that in advanced cardiac life support as well, but 200 joules biphasic if hemodynamically unstable at any point, and SBPs are less than 90, and the patient has chest pain on altered consciousness. All right, so it's listed as third line for refractory PSVT, but first line for hemodynamic instability. All right, and then prevention and long-term prevention to prevent the recurrent of SVT. We have beta blockers, atenolol, metoprolol, sotalol, and or verapamil. Second line would be we add flecainide only if no structural diseases, and definite would be radiofrequency catheter ablation. All right, and it has a 95% success rate. Now moving on to ventricular tachycardia and ventricular fibrillation. All right, now why is it important is that because ventricular tachycardia, non-sustained beta blocker or amiodarone or sotalol, we give that. And if it's sustained, so you see the difference in the treatment between sustained and non-sustained, right? So ventricular tachycardia, if it's non-sustained, we give them beta blockers or amiodarone or sotalol. And if it's sustained, we give them amiodarone. And if it's not stable, we do DC shock. Again, not stable, DC shock. And for ventricular fibrillation, we have DC cardioversion. So VF, we have to give them DC cardioversion. All right, and IV adrenaline, if fine VF, then DC cardioversion. So if the ventricular fibrillation is very fine, we give them first IV adrenaline and then DC cardioversion, and amiodarone is given as maintenance. Now class 3 if it's recurrent, and for torsades we have to correct the causes of why this is happening. So if it's potassium, we seize the drug, and if it's increasing QT, cardiac pacing should be done IV magnesium sulfate, IV isoprenaline. All right, now I've seen the questions for this, but it's covered more thoroughly in the ALS and BLS in the emergency section of this guidebook, so I think that would be easier for you to go over it over there. All right, now VT, VF types. We have non-sustained VT, which is VT less than 30 seconds, and it's self-terminating, no hemodynamic compromise, and stable. And we don't commence any drug therapy without performing echocardiography first. And if there is structural disease, we give them beta blocker or amiodarone. If no structural disease, we reassure and refer to cardiologist. All right. Now, if the patient has sustained VT, that means the VT was more than 30 seconds or requiring intervention, and SBP was maintained to be more than 90, and the patient was conscious with no chest pain. We give them IV amiodarone, 300 mg over 20 to 60 minutes, then 900 mg over 24 hours infusion. And then we correct the electrolyte. Target is going to be 4.5 to 5, and we treat the precipitants of the sustained VT. Now, if the patient is unstable, so you already know, if the patient is unstable with hemodynamic compromise, immediate synchronized cardioversion, all right, not unsynchronized. So the difference between that is going to be that the machine is going to know when to shock the patient based on the ECG of that patient, and that could help the patient massively. If it's unsynchronized, it's going to make the patient worse, all right? So that's why, the new machines that we have, that we went over in the ALS course that I took, it was amazing because we just place the pads, the machine assesses and shocks when it's time based on the ECG. All right, and now moving on to torsades de pointes, we have polymorphic VT. So QRS morphology is going to have twists around isoelectric line and is associated with long QT intervals. And the patient can deteriorate to VF. So the first is to stop all QT prolonging drugs, so sotalol, amiodarone, antipsychotics, macrolides, fluoroquinolones, TCAs, and then we correct the potassium. So potassium is the most important one because the way I remember is that the cardiac muscle or any muscle is like a salty banana. Banana is potassium, salt is sodium. So we have to correct the electrolytes inside the muscle first so that it can return to proper contraction. So potassium needs correction. Then we do magnesium sulfate, then we have cardiac pacing, then IV sopranolone, and IV MgSO4 2 grams IV bolus. So again, magnesium sulfate, IV bolus for 2 grams. And then we have VFib, ventricular fibrillation versus chaotic pulseless rhythm. It's an arrest. We have to do CPR and unsynchronized defibrillation in this patient. All right. Now the difference between the ventricular fibrillation and an unstable VT is that it has synchronized DC cardioversion and this has unsynchronized DC cardioversion. And whatever is given here, this is basically the the algorithm for ALS. For CPR basically. So there's unsynchronized defibrillation of 200 joules if there's no pulse, adrenaline 1 mg IV every 3 to 5 minutes, and after the third shock we give amiodarone 300 mg IV bolus, and then we continue the cycle until we get a pulse, and yeah, the patient hopefully recovers. All right, so the most important AMC trap is going to be wide complex tachycardia, and always treat as VT unless definitively proven to be SVT with aberrancy. And a hemodynamically compromised patient with wide QRS tachycardia, give synchronized DC cardioversion and never give verapamil for wide complex tachycardia. If it's VT, verapamil causes catastrophic hemodynamic complex. So you can just imagine if this patient comes to you in your GP setting or any setting, and this is how they present to you, or you see someone collapse on the road, you see their ECG, you see a VT, and then you give them verapamil. The patient's probably, patient's family should start planning their funeral and suing you as a doctor, which is really horrible. But if you remember this point, it should keep you safe from that. Now moving on to the next topic, which is atrioventricular blocks. So first degree, second degree, third degree. And I didn't put the ECGs in yet because it's one of the easiest one, and if you can just read it and memorize these points, it will be easy for you to deduce the ECG, because the more ECGs we go over, it's more confusing, but Mobitz is the easiest ones to remember. So first degree AV heart block is going to have long PR intervals, so PR interval more than 5 small squares, and there are P conducts, just very slow. You see P waves. All right, now this is going to be asymptomatic, benign, and common in athletes because of the high vagal tone, and it could also be seen in inferior MI and digoxin toxicity, and no treatment is needed, and we just monitor. And sometimes I've also come across this question while doing the recalls that the finding for the first degree AV block was just incidental. And what do we do for this? If there's no patient, if there's no symptoms, we don't do anything, we just monitor the patient. All right, and if the patient does have symptoms, or if the patient did have a history, then we have to investigate what is the cause of this new finding. All right. Now moving on to Mobitz type 1, the Wenckebach, which is the second degree heart block. There is progressive P-wave interval lengthening. I think this is the most famous one amongst the students because it's the easiest one to remember. and there's lengthening, and then suddenly there's a beat drop. It could be 2 to 1, it could be 3 to 1. I've also seen 4 to 1. And then the clinical significance, it's benign and often in inferior MI or vagal states, and usually asymptomatic and characteristic ladder pattern. So no treatment if it's reversible, if drug induced. All right, so it's because of drugs. We can remove those drugs, and it's back to normal. Then second degree is this. This is where the this topic starts getting more juicy, I would say, because there's a lot of treatment for this. So second degree morbits is fixed PR interval and then suddenly unpredictable drop. All right, so drop QRS with no preceding PR lengthening. This is serious because it's unpredictable and can deteriorate to complete heart block without warning. So Stokes-Adams attacks, and higher risk than morbid type 1. So we consider pacing, and pacing if the patient, if this second degree heart block is problematic. If interior MI, we have to do urgent temporary pacing, and any symptomatic morbid type 2, we have to get them a pacemaker, because you don't know when suddenly it's going to stop. The way I like to think about second degree morbids, it's basically one of those old tube lights that we used to have. So before the LEDs that we use now, we had to switch on the light, and then we wait for the flash, the tube lights to flash and then suddenly turn on. So the way I like to think about it is that sometimes it flashes and then sometimes it complete stops. So we don't want that to happen, so that's why you get the pacemaker for them. All right, now third degree, it's complete heart block, and it's one of the most dangerous, life-threatening. There's complete AV dissociation, so P waves and QRS are not aligning at all. All right, and P waves is doing its own thing, QRS is doing its own thing. All right, so there's no relationship. And this is escape rhythms, junctional with narrow, rates are between 40 to 60, or ventricular, which is wide, 20 to 40 rate. And this is life-threatening. According to Murtagh, Stokes-Adams attacks are there's transient bradycardia due to complete heart block. Then the patient can have syncope, pre-syncope, and hemodynamic compromise and heart failure. So if it's acute, especially in inferior MI, we give atropine. All right, and the dosages for atropine are important in this. So 0.5 mg to 1 mg, and the maximum is 3 mg. And then we have temporary transvenous pacing. Then adrenaline is IV if the patient is severe. And if the patient, this is all acute. All right, so this is all acute. Now if the patient is presenting with this on a chronic presentation, then we have to give them a permanent pacemaker. You could just think that if the second degree we were considering pacemaker, third degree obviously we'll go for pacemaker as well. All right, so we have temporary pacing, adrenal IV, and atropine, and then permanent pacing and isoprenaline for chronic cases. Now SSS, which is the sick sinus syndrome, we have alternating bradycardia and tachycardia on Holter monitoring, and sinus pauses. In this we have AF and dizziness, even syncope, and those are the signs of SSS. And this again we have to give them permanent pacemaker. So anything below second degree, we have to consider pacemakers. All right. All right, now coming up to Wolff-Parkinson-White syndrome, WPW, and it has the structural basis for the arrhythmia of SVT in WPW syndrome is an accessory pathway that bypasses the AV node. And a typical ECG shows a short PR interval and slurred upstroke of the QRS complex, delta waves, which we went over earlier. And patients are prone to sudden attacks of SVT. Up to 30% of patients will develop AFib or flutter. Even one episode of PSVT requires consideration for radiofrequency ablation, because it can go into WPW, WPW to AF, and the patient can deteriorate after that. All right, so ECG pattern, we already went over that. Short short PR interval, delta waves, and broad QRS complexes. Then WPW type A is that there's a positive delta in V1, dominant R in V1, which is left-sided accessory pathway. B is going to be right-sided, where there's negative delta wave in V1 and dominant S in V1. All right, in this we had dominant R, we have dominant S in V1, and this means that the accessory pathway is right-sided. I've yet to see a question about this, but it's really essential information I think all doctors should have when they see the ECG. Because it can give them better understanding of the patient. So arrhythmias in WPW, SVT with narrow complex, anterograde through the AV node, retrograde through the AP, and this is the most common. Then pre-excited AF, wide, irregular, fast. All right, and this is the most dangerous condition that the patient can be in. Now, this is an important section, that what drugs do we avoid in WPW? We have to give them, avoid all rate altering drugs. So it could be digoxin. It's going to shorten the accessory pathway and the refractory period, leading to acceleration and pre-excitation. So we have a risk of VF. All right, verapamil, same mechanism. Adenosine can be used for narrow complex SVT, but avoid in pre-excited AF. All right, so we don't give them if the patient had or has symptoms of pre-excited AF, and we could use them in narrow complex for SVT. All right, so these are some important points that if you can memorize, you can score well on this section. And again, treatment for SVT is the same as treatment for the normal SVT. Vagal maneuver and then adenosine. Again, adenosine we give them in narrow complexes SVT, but we avoid in pre-excited AF. Now, the treatment of pre-excited AF, stable and wide. So remember, stable and wide is flecainide IV or procainamide IV. Slows accessory pathway conduction, and not digoxin and not verapamil. All right. Now, the treatment for unstable, again, unstable, we do synchronized DC cardioversion. And the definitive treatment is RFA. And even one episode of PSVT, according to John Murtagh, is consideration for RFA. And it has a success rate of 95%. All right. Now we go on to the classification. And this was taken from John Murtagh, but I've not seen any questions for the AMC exams. However, in some of the notes, I've seen a few key points regarding these classification of different drugs. So class 1A would be sodium channel blockers, which slow the conduction and prolong repolarization. So these are the important drugs for this, and they are rarely used now because of they used to be used for VT and AF historically. All right, so quinidine syncope could mean torsades, and procainamide is used in WPW and AF. Quinidine is syncope is considered torsades. All right. Now, class 1B is sodium channel blockers for fast channels and mainly ventricular. All right. Lidocaine. So lidocaine, I've seen this in one of the questions, and it's used in VTVF in acute MI. All right. Again, this was VTVF, but this is VTVF in acute MI. So lidocaine IV for acute VT and not orally effective. Class 1C is sodium channel blockers, so flecainide, so SVT prevention, AF rhythm control. Remember, we just read it up in the WPW section that for AF rhythm control, we have flecainide, and we never prescribe patients with reduced left ventricular function, proarrhythmics, and flecainide CI in contraindicated in structural heart diseases and HFrEF. All right, so any structural heart diseases, flecainide, we don't give that. All right. Now, class 2 is beta adrenergic blockade, which slows SA and AV nodes. So atenolol, metoprolol, sotalol. So it causes bradycardia. All right. So any disease that has the underlying causes to be a lot of depolarization, excitation, and increase in heart rate, we give, logically that's where we use beta blockers. So SVT, AF, and post-MI VT prevention. All right. So most widely used for first line for SVT, all right, prevention. So SVT prevention, we give beta blockers. Now, potassium channel blockade, which are going to prolong the action and potential and refractory period. So amiodarone, sotalol. AF cardioversion and maintenance VTVF, and for resistant SVT. Amiodarone is the most effective antiarrhythmic, and many side effects such as pulmonary fibrosis, thyroid, hepatic photosensitivity, corneal depositions. In SVT, we have 200 mg per day, but for VT, we have 400 mg. So S is basically half. All right, so SVT is 200, and just VT is 400 mg per day. All right, and sotalol is also a beta blocker, class 2+3. Then we have class 4, which are CCBs, verapamil, diltiazem, and it's used in SVT acute termination and AF for rate control. And avoid if the patient is taking beta blockers, avoid in WPW, and avoid in wide complex tachycardia and contraindicated in systolic heart failure, right? Because it reduces the rate, it causes bradycardia. and I've not come across these, but adenosine, most important one, SVT, acute termination. All right, so this is ACLS all over again, the pathways, then unclassified digoxin, narrow therapeutic window, contraindicated in WPW, toxicity, nausea, xanthopsia, and arrhythmias. We read what was xanthopsia in the last lecture. It's when the patient has a yellow-green tint on their vision. All right. Now moving on to the the last section. So finally, we are at the end of this chapter, and these are the questions. These are based on all of the topics that we went through right now, and I think that's the end of this lecture, of this video. These are all of the key numbers, all right, to remember, and these are the references used. And the important fact is that I've included John Murtagh, I've included therapeutic guidelines, and I've also included the ECGs, the links to the ECGs, because they keep on updating. That's why I didn't put any in this PDF, and they keep on changing and adding more examples. So I think that would be a disservice to put the old ECGs as well. And if you go into the website, you can find the updated ECGs. So anyways, I hope you guys liked the class for today. And the next, which is the final chapter we have, is hypertension. And this is also a very interesting topic, but anyways, we'll this video is already pretty long. We'll end this video today here, and then I hope you guys enjoyed the video. If you guys have any questions, if you guys have any doubts, if you guys have any questions, or if any of the details or whatever I mentioned was wrong, please feel free to message me. Feel free to comment down below. Have any questions, comment them, even if it's about studying, about registration for AMC, or anything related to AMC basically. And if I can't answer, somebody who reads this could be able to answer you, but I go through all of the comments. And again, the WhatsApp group link is given in the description below. That's where you have a lot of discussions regarding questions and recalls, and the chapter link is also going to be in the description below. All right, have a good day. Bye.